appreciate your support and interest in contributing to the knowledge economy. My name is Dan Stringer, and I'm a member of the Board of Directors of Gateway Centre of Excellence in Rural Health. Gateway is located in Goderich, Ontario, Canada, and to our knowledge is the only rural health research centre in Canada governed by a community-based volunteer group. Partnered with several academic centres and healthcare facilities, Gateway aims to advance rural health teaching and research across Huron, Perth, Grey, and Bruce counties. Our mission is to improve the health and quality of life of rural residents through research, education, and communication. Almost 2 years ago, Gateway launched this virtual lecture series, with social isolation being top of mind, and as the COVID-19 restrictions continued to heighten. There was no better time to launch this initiative. Through this lecture series, we hope to promote a culture of rural health knowledge and innovation while virtually connecting individuals and communities to help reduce social isolation. We give diplomas at the end of each semester to those with perfect attendance to recognize your commitment to and involvement with this education series. Today's speaker is Dr. Al Lauzon. Al is a member of the Gateway Board of Directors and serves as the Research Chair of Rural Change and Development. In his spare time, Al is a professor in the School of Environmental Design and Rural Development at the University of Guelph. He's been very active at Gateway, bringing research projects to this rural region, assisting Gateway students with their research, and training our summer research assistants in research methodology. In the past, Al has served as chair of the board of directors for the Ingersoll Hospital. Al's current research is focused on processes of change and transformation. He's currently involved with PhD student Cassandra Bryant in examining the impact of COVID-19 on rural healthcare workers, and with PhD candidate Charlene Lindsay examining the experience of hospital leadership during the pandemic. As Al approaches retirement, he plans to write a bestseller tentatively titled Living, Learning, and Loving During the Anthropocene, The Emergence of the Participatory Worldview. The title of Al's presentation today is Rural Senior Food Security and Insecurity, the Case of 4 Counties. With Al today are panelists Grace Bonnett, Rim Mouhaffel, and Dr. Kyle Whitfield. Dr. Whitfield is an associate professor at the University of Alberta in Edmonton at the School of Urban and Regional Planning. The focus of her teaching is community planning and engagement and planning for social equity. The focus of her research is about how to enhance the capacity of older adults to participate fully in decision-making about key issues that are relevant to them. Dr. Whitfield is also a registered professional planner. Rim Mouhaffel is the public health dietitian at the Timiskaming Health Unit in Northeastern Ontario. She has a Bachelor of Science degree in Nutrition and Dietetics from the American University in Beirut, Lebanon. She completed her Master of Public Health in Nutrition and Dietetics with collaborative specializations in global health and public health policy at the Dalla Lana School of Public Health in Toronto. In her practice, Rim uses systems thinking, health equity, and food justice lenses to promote nutrition and well-being. She recognizes the intersectionality between nutrition and the social determinants of health and advocates for upstream level interventions to influence public health policy provincially and nationally. Grace Bonnett makes Huron County her home. She graduated from the University of Toronto with a Bachelor of Science degree in 2020. Her educational background includes the study of human biology, immunology, sociology, and human physiology, and the mechanisms of disease. Grace has come to appreciate that although biological mechanisms contribute to health outcomes, health is more than physiology. It's also the product of the communities we live in, the foods we eat, and the conversations we have. Grace has been with Gateway now for over 4 years. She's seeing how rural health and research can be productive partners. Currently, Grace has been immersed in the Be Well, Work Well research project, as well as working with the Huron Perth Public Health Destination Prosperity Project. Thank you, panelists, for your time and insight today and in the preparation discussions for this lecture. And now I'll pass it back to you, Al, to start the discussion.
Okay, thanks, Dan. I'm just going to do a presentation for a few minutes, and I'm going to share my screen. I've got some slides. There's not a lot on them, and hopefully this works. I've been having a little bit of computer problems, but we'll hang in there. And okay, first of all, I'd like to thank Gateway for this opportunity to speak today. It's great, and I always enjoy the Gateway lectures, so hopefully you'll find some value in what we're going to talk about today. So a lot of my research actually comes out of my experience of living rurally. Dan mentioned that I was chair of a hospital board. My terms expired, but it was really during that term where this research sort of has its roots, and part of what we were dealing with at the board level on sort of a continuous basis was the whole issue of alternative level of care, where seniors were occupying acute care beds and for prolonged times. And we're all very aware of alternative level of care right now, as we see the new legislation that allows hospitals to move seniors out to empty spaces in long-term care, not of their choice. And that's another issue, but I won't go into that today. So we're really experiencing a demographic challenge with the baby boomers sort of moving through the life cycle, and they're now entering sort of the last phase of the life cycle. And so we're seeing an aging population. In 2022, or currently 19% of the population is seniors, and by 2030, it's projected that it'll be 22.5%. So it's going up. This aging demographic is having a tremendous impact on the healthcare system, and we're moving from a healthcare system that was designed for acute care to one that needs to be designed for acute care, but needs to accommodate the issues and the demands of chronic care too. Most seniors, as they age, suffer from multiple comorbidities, and again, this is the baby boomer generation, of which I'm also part of. Demographics over 65 utilize more healthcare resources. And if you look at that graph, you can see, in the first years of life, we use quite a few resources. And then as we approach the end of life, we use an increasing amount of resources. So
sorry to interrupt, Al.
Yeah.
Sorry to interrupt. We're not seeing the slides advance on our side.
Oh, really? Okay. I don't know why. I think I just probably lost the slides too.
There we go. We see the graph now. Yeah.
I can't. Okay. I hopefully I can change it. This is what my computer's been doing, so my apologies. So I'm just going to continue to talk, and hopefully the slides will advance when I advance them, although I can't see them. So anyways, you're looking at a graph. So if we look at sort of healthcare usage, currently 75 to 79 would use a little over $11,000 per year, 85 to 89, a little over 22,000. And if you're over 90, it would be sort of in the realm of 30,000. Healthcare expenditures on those over 65 in 2019 are 45.5% of the healthcare budget. And it's projected by 2040, if everything stays the same, that they'll have or take up 71% of the budget. So we're currently recognized that the best and preferred care for seniors, and this is by seniors, is to stay in their homes. So we need to look at ways of helping them stay in their homes. When Tommy Douglas first brought universal health care to the province of Saskatchewan, he said we need to provide health care to people when and where they need it. And we've worked very hard at that. And up until recently, we've been quite successful. But he also said we need to develop policies that keep people healthy. I think too often we fail on this latter point. One area that's critical to health and well-being is food, and in particular, diet as a means of navigating, managing, or mitigating many chronic conditions. In absence of an adequate diet, many chronic conditions worsen. Food insecurity, or the lack of adequate nutrition also takes its toll in terms of mental health. And 40% of those that experience extreme food insecurity also have suicidal thoughts, suffer from recessive thoughts, or a major depressive episode and anxiety. This raises the questions, really, do seniors get enough food, and do they get the right kind of food? I think this is very revealing. A study by the Canadian Malnutrition Task Force in 2016 reported that over half the seniors admitted to the hospital were identified as being malnourished. There's been little research on rural food insecurity and very little on rural seniors. This study really sought to understand rural seniors' relationship to food and food security and insecurity. This is important because we now know that rural is a critical variable in the health and well-being of people. In fact, rural is now considered a determinant of health, as is food insecurity. Did that move my slide, Jay?
Yeah, we now see the slide with the two pictures and food security, insecurity.
Okay, all right, that's fine. Then it will move it. So what do we mean by food security and food insecurity? Food insecurity is really access to safe and nutritious food that is available and easily accessible and can be secured in socially acceptable ways without resorting to emergency food services. Food insecurity is essentially the opposite: the inability to acquire or consume an adequate diet or sufficient quantity of food in socially acceptable ways, or simply the uncertainty that one will be able to do so. I want to talk a little bit about sort of seniors and seniors' health. The study that we looked at were only focused on seniors who lived independently, and that accounts for 92% of Canadians seniors currently live independently, and about 7% have incomes below the low income cutoff level. And for those who are unattached, that is actually at 17%. In 2017, 2018, 7% of seniors were food insecure. And that's been has gone up currently to almost 9% in 2022. We know that rural populations are aging. More seniors are becoming food insecure, and rural populations are aging more quickly than urban populations. So this may be of a greater issue and concern in rural communities as we move through this. We also know that rural people are less healthy than urban people, which often surprises people. And we also need to deal with the escalating cases of dementia. And this will only worsen over the coming years. In 2016 in Ontario, there were 228,000 diagnosed cases. And it's projected that by 2038, there will be 430,000 cases. This is an extremely vulnerable elderly population, and will have a real demand or place a real demand on the healthcare system. Seniors are often hospitalized because of chronic conditions, and often this is as a result of a failure to manage them appropriately. And we know that a senior entering the hospital can enter into a downward spiral in terms of their health and well-being. For example, hospitalization can lead to infection or hospital delirium, and that is hospital delirium is often misdiagnosed as dementia and can have long-term effects on cognitive functioning, creating long-term disability. Furthermore, seniors are more likely to suffer from disabilities that make carrying out daily chores like meal preparation challenging. Thus, seniors who are suffering from food insecurity are at a greater risk of nutritional deficiency, which can exacerbate chronic disease and exacerbate the symptoms associated with dementia and depression. Food insecurity is usually identified as a financial issue, but with rural seniors, it could be an issue of financial access. It could be an issue of physical access. It could be an issue of personal capacity to prepare food, or it could be simply a lack of motivation to do so. Furthermore, rural seniors often have lower levels of functional and health literacy, and hence it can be somewhat difficult sometimes to manage their health and their diets. In 2008, Teen Food Banks Canada noted that senior frequency of food bank usage by seniors had increased by 10% in 1 year. And we know that roughly 22% of people who experience food insecurity actually frequent food banks. So that really leaves a question of what's happening for the other 78% of food insecure people. Okay, I just switched slides, so hopefully it switched. I want to look at the bit. So the study consists of interviews with stakeholders and interviews with seniors. And so in the first year of the study, we interviewed stakeholders. We did 76 interviews with healthcare professionals, food service providers, home care workers, municipality employees, and public health employees across the 4 counties of Huron, Perth, Bruce, and Grey. The main issue that was identified through those interviews was financial in terms of its relationship to food insecurity. It was noted that limited income or income doesn't keep up with inflation, and grocery stores in small towns are often more expensive. And as we look at the current inflation in the Globe and Mail this morning when I was reading it, it talked about the next year is likely to see another 7% inflation in food prices, which is going to mean more people are food insecure, including seniors. They also identified in rural areas transportation challenges were problematic. So access to grocery stores may not be convenient. Individuals may not have a license or a car or be able to drive. They may be isolated socially with no one to help. There's a lack of public transportation in rural areas, so that's not an avenue. And cabs are a very expensive way of sort of getting around, particularly if you're on a limited income. So in a lot of ways, those at greatest risk are already the most vulnerable. Complicating that is a lack of health literacy, and which can make chronic disease management, and that was noted by that. When we asked them about sort of alternatives and that, or sources of food, they talked about food banks as one potential source of food, but the transportation issues are still there, and the food banks are often in sort of the major population centers in rural areas. They also noted that there's often a stigmatization of frequenting food banks, and that seniors are resistant to that. And there's also the idea that they have to provide personal information that is very uncomfortable from them, and they may not frequent the food bank because they don't want to provide that type of information. It was also noted that the quality of food in food banks was lacking, and often carbohydrate heavy and processed foods. The other element of that around food banks is they also maintain that food banks really only serve high functioning adults and really can't deal with frail seniors. They also reported that home care might be as a potential option, but the shortage of home care workers made it difficult in rural areas in particular. And usually home care workers don't have time to actually assist with very much meal assistance. They noted that private food assistance or private home care is available, but the costs, they said, ranged from $35 to $80 per hour, making it unaffordable for many seniors. Meals on Wheels was also identified as another service. However, it provides limited service because of low population density. And for some, it's too expensive. It was noted, this study was right after the Ford government, or shortly after the Ford government came in, and they, the increase in minimum wage increased the prices of Meals on Wheels, which actually put it out of the range of some people who had normally or had recently been accessing the service. And of course, with increasing inflation in the last year and the incoming inflation in food prices, it will actually exclude more seniors if they have to raise their prices. One of the things that came up that I hadn't really thought about was the issue of poor oral health. And they talked about people not having dental care, not being able to afford dentures, to having unhealthy teeth, and their inability to actually eat healthy food and process it. So that was an issue that I hadn't really thought about, to be honest. When we talked to some of the healthcare professionals, and including physicians, one of the things that came out from the independent practitioners is that they do a limited amount of case management around food, and often do not include diet as part of a patient history, nor do they deal with it on visits unless a visit deals with diet specifically or there's a noticeable weight loss. They noted that really what seniors need are dietitians, but for those independent practitioners, there's not a dietitian associated with medical practice. They noted that there are some that are available for fee for service, which again, in a lot of cases, for those who most likely need it the most, may not be affordable. So the 4 top barriers to food insecurity for each of the groups we interviewed were healthcare professionals, and they identified income as the main reason, followed by access, social isolation, and mobility. Home care workers identified social isolation, income, access, and lifestyle choices. I think the home care workers are an interesting group because they're the only ones who have insight into what actually happens in the senior's home. Then the service providers and municipal and public health employees identified income, access, social isolation, and rising food costs. We then went on to do interviews with the seniors, and we interviewed 80 seniors across the 4 counties. The interviews were conducted by either phone or Zoom, and this was not our preferred method, but because of the pandemic, we didn't feel that we had much choice. We did delay the data collection for a year in the hopes that the pandemic would disappear. It didn't. And one of the disadvantages, I think, was the ability to establish the type of rapport that I had hoped that we could get with seniors to get a depth. But we did the best we could through the phone and Zoom interviews. So in our interviews, really, we found that rural seniors are a diverse population and vary greatly among a number of variables. Through this research, we've identified 4 demographic variables which are associated with greater risk for food insecurity. And these won't be of any surprise probably to most people. Rural females are more likely to be food insecure than rural males. The older the rural senior, the more likely they will be food insecure. The lower the annual income of the rural senior, the more likely they will be food insecure. And those rural seniors who live alone are more likely to be food insecure than those others who live with someone. We need to understand that these variables characterize certain seniors and often occur and interact together. In other words, for example, females who are older, have lower income, and are living alone are the most likely to be at risk of becoming food insecure. This population is more likely to cite also having a condition or a disability that makes meal preparation difficult. When the respondents were asked about sort of a medical condition that they had to have some type of restriction on their diet, 57% of our respondents reported that they did have a medical condition that required monitoring their diet. What was a little bit worrisome, though, is when we asked if they complied with those dietary restrictions, 43.5% said that they didn't comply with their restrictions. This really increases the risk that non-compliance with dietary restrictions may not be dealt with until chronic conditions worsen, medical intervention is required, and this leads to increased healthcare costs and creates greater vulnerabilities for the senior. Part of the mitigating the negative consequences is, again, having access to nutritious food, but it's not just access, it's also consumption. So when we think about food consumption and barriers in the existing literature, the main reason given for food insecurity is usually financial, and our stakeholders who were interviewed identified that for the most part. The study of rural seniors, however, means that they may be able to afford food, and they may even have physical access, but they may lack the capacity to prepare food, particularly if they have a disability of some sort, arthritis or vision, or they may lack the motivation to do so. And we found in our respondents that the lack of motivation usually goes with those people who are living on their own, and they would sort of say, why bother making a meal for one person? So there's a chain of prerequisites that must be met in order to ensure a senior is getting an adequate diet. In order to achieve food security, a rural senior must have physical access to nutritious food, must have the means to pay for it, must have the capacity to prepare it, and the motivation to do so. If any of these conditions is not met, then the senior will not consume nutritious food. Given this chain of events, it may be more prudent to distinguish this as nutritional security rather than food insecurity. Food insecurity in the literature is often simply reduced to a financial issue rather than looking at the complexity of accessing food through to consumption. Given the health status of seniors, it would be more accurate to refer to this as nutritional risk. In the research literature, it discusses that rural areas are often characterized by food deserts and swamps. In other words, the availability of nutritious food is limited, and food also tends to be more expensive in our rural areas. Our stakeholders that we interviewed in the first year of the study echoed this concern in their interviews. However, when we asked respondents in this study where they get their groceries from, they all reported the grocery store. So 100% of the sample reported that they get groceries from a regular grocery store. In addition, some mentioned farmers markets or specialty shops. Only 2 respondents reported occasionally accessing groceries from a variety store, which are likely to have a lesser quality of nutritious food available, and if available, is likely to be more expensive than the grocery store. When we asked them how they get their groceries, 76% reported that they drove their own cars, and 85% report going grocery shopping weekly. There are, however, significant differences by income, with 54% of those earning $50,000 or less driving their own car to get groceries versus 91% of those earning more than $50,000 a year. It should also be noted that for those 80 years or older, had 50% report that someone else picked up their groceries or that they had them delivered, compared to 8.5% for those under the age of 80. So how they acquire their groceries by age is very different. It was also found that those with lower incomes are more likely to have someone get their groceries or have them delivered compared to the higher income group. The reality is that dependence on someone else to get your groceries makes you more vulnerable to food insecurity in the event that something happens to your source of groceries. We saw some evidence of this for seniors who reported that sometimes they cannot get groceries because the individual who gets them for them is ill or not available. So maintaining one's social networks will become imperative for some rural seniors who are dependent upon others. Stakeholders highlighted the issue of social networks when they noted that often people who retire to rural communities often bring significant financial capital, but have little social capital. In the event that they lose a partner or become ill, they may be at a disadvantage and may be socially isolated and prevented from getting the assistance they need. Long-standing rural seniors may also experience this issue to some degree as family members leave the rural community for new opportunities. One issue that is not often considered is the frequency of grocery purchases. Most of our respondents reported getting groceries once a week or more, and a few every 2 weeks. However, we did have some respondents who get them once a month or whenever they can, as they said. Longer intervals between grocery shopping can lead to influencing the type of food bought, with an emphasis on foods that will not spoil and in all likelihood may be less healthy. Food selection may also be made based on difficulty of preparation. For some who have limited physical capacity or sight issues, for example, one of the things we offered if they or asked them if are there certain foods that they avoid buying because of the packaging. And a number of them, not a large percentage, but a number of the older respondents reported that yes, they actually packaging actually excludes purchasing some forms of food. Services such as Meals on Wheels can be helpful in meeting some of the dietary needs for rural seniors, and they noted that. But they also noted, or at least some of them did, that often they produce food, or not often, but sometimes they produce food that they don't normally eat or they dislike. One example that was given was curried chickpeas. It was also noted another alternative was food banks, but stakeholders reported that food banks do not provide the most nutritious food, and only 2 of our respondents reported using food banks, but reported that they were quite satisfied with the experience. one of the dangers of food insecurity in the elderly is it can facilitate a downward spiral in their health and well-being. As noted previously, a significant proportion of seniors have chronic diseases that require dietary restrictions. We know from our seniors' interviews that many do not comply with their dietary restrictions, which threatens to worsen their chronic conditions. Consequently, an inadequate diet may worsen the chronic conditions, and the individual becomes increasingly ill and do not feel like eating or cooking, which worsens the condition and it deteriorates until such time that medical intervention may be required. Rural seniors then become increasingly ill and the quality of life suffers. At the same time, it takes up more of our healthcare resources. This comes back to research by Allard, who reported that 50% of the seniors admitted to hospitals are suffering from malnutrition, making their condition worse and any hospital stay longer. And we know for any senior, a hospital stay represents a potential risk. This issue is further complicated by a lack of adequate number of physicians in rural areas and other healthcare support services, often leaving the only option for healthcare being the emergency room, which we know is incredibly problematic these days. Okay, so I just want to provide a little bit of summary. I'm just switching around. I can actually see my slides now if I look at my laptop rather than the big screen. So I'll do that. Summary and conclusions. Food insecurity is a growing problem and will continue to be a growing problem for seniors. Particularly, we will have more seniors with inflation and the increase in food prices, and often sort of the stabilization or the stagnation of senior income. It will create greater barriers to food security. Rural senior food insecurity is sufficiently different and needs to be dealt with through rural solutions, not through urban solutions transferred to rural areas. Growing food insecurity means a decline in the quality of life for seniors as the baby boomers continue to age and live longer. Increased food insecurity will lead to increased healthcare costs and potentially long-term care demand. Current means of meeting challenges of food insecurity, namely food banks, are not adequate. And that was to be a temporary solution until we resolve the issue of poverty. And it's now a permanent part of the landscape in a way that we think of dealing with food insecurity. We need to find some new solutions. We know that the pandemic has increased food insecurity for many, including seniors, but we don't know to what extent. Food insecurity, or what we've called nutritional insecurity, exacerbates chronic conditions, undermining the quality of life of rural seniors, and may lead to medical interventions. That means using healthcare resources unnecessarily when the problem could have been managed by ensuring rural seniors have adequate nutritious food. Rim talked about, or in her introduction, about looking at upstream solutions, and this is food. Adequate food is an upstream solution to part of the challenges that we're having with the healthcare, the demands on the healthcare system. We also need to consider that having an adequate diet is a human right, as noted under the United Nations Declaration of Human Rights, which Canada signed in 1948 and recommitted to with Canada's Charter of Rights and Freedoms signed in 1982. This is an obligation and responsibility that governments of Canada must ensure is met. But perhaps just as important, food insecurity, or nutritional insecurity as we're calling it in seniors, is a public health issue that when not dealt with can lead to increased healthcare costs. Dealing with upstream issues such as food and nutritional security is much more cost effective and cheaper than dealing with it when it requires expensive medical intervention or hospitalization in an area when we're looking to rationalize healthcare costs. And if we go back to that first graph that I showed and the expenses and how they increase over the course of the life cycle, we can see that if we could reduce those costs and invest them in things, upstream solutions, it may actually lessen the demands on the healthcare system and also lessen the financial requirements. So food and nutritional insecurity, when it occurs, makes seniors less healthy, undermining their quality of life. Dealing with the issue and mitigation of food and nutritional security is in the interest of rural seniors, rural communities, the medical community, and governments at all levels. We must acknowledge that as a society, we have a responsibility to ensure that seniors in our communities are receiving and consuming adequate nutrition. This is an issue that will continue as baby boomers move through the final stages of the life cycle. Now, I would ask you to imagine in your mind's eye the landscapes of the 4 counties. When you do, hopefully you'll see some of the most productive agricultural land in the world. This then raises a question then, why are people in these areas going hungry? Food insecurity is an economic and a social problem. It's a health and a healthcare problem, and it is also a food production system problem. It is ironic that some of the most productive agricultural land in the world have people in these regions that still go hungry. Thank you. That's it, Jay. So I'm going to ask you to bear with me for a minute. Can you stop my share, Jay?
I certainly can. Just give me a moment here.
Okay, I
There
can't.
we go.
Thank you. So first, I have the benefit of having some highly qualified people to sit on with me and to ask me questions or to challenge me or to for me to ask them the questions. So I'm just going to open it up to the panel, and any of the panel members can jump in. Any thoughts on what you heard during the presentation? Any disagreements or whatever you'd like to say? So I'm going to ask you to simply unmute and jump in if you have something to say.
I'm happy to start. My name's Kyle Whitfield from the University of Alberta, and I do a lot of work with older adults. And the kind of challenges that I'm seeing is, first of all, around the pandemic, which has recently fostered a scenario and an environment where older adults are isolated and more isolated than they've been before. And this is obviously resulting in social isolation, which is a major challenge. The other challenge is about older adults that have limited mobility. This makes it hard to access food, to get around in town, and to access services that they may need. One reason this is occurring is because of poor or even a lack of transportation. I've got two more challenges that I'm noticing and that we've experienced in the work that we've done here. And that is, we're not hearing and involving the voice of older adults themselves. We may be asking them what they need, but we're not taking that next step to involve them in the planning and decision-making for solutions. And so we've really got to find a way to not just ask them the question, but next to integrate them in decision-making and planning. And finally, ageism, which is unfortunately alive and well. And that is resulting in an overall lack of even seeing seniors as being an issue. Yes, population is increasing, but I don't think that's enough of a reason to identify older adults as having needs and needing supports. So we've got to, I think, our lack of identifying older adults as being significant and being capacity builders in our communities is really lacking. So I'll hand it over to whoever would like to go next.
Just a couple comments, Kyle. I think you raised some really interesting issues, and your first one on social isolation in the pandemic, that is something that we asked the seniors about. And there was really mixed responses from that. It had negative consequences through to it had positive consequences, and which was interesting. And I haven't sort of broken the data down yet, but I suspect a lot of that may be along age and income. And that particularly as it relates to food acquisition for those older folks who are dependent on other people. And some people said it was a positive thing. They had more time to cook because they were at home more. For some, it really limited their access to food. For others, they said it didn't really have an impact. They still did their regular shopping. The only change that they may have done is whereas before they may have gone to 2 or 3 grocery stores, they usually just went to 1 grocery stores. And sometimes they timed when they would go to the grocery store to try go at times that were less busy. But I think they're, you know, and that's one of the interesting things about this population as it relates to food is it's a very diverse population socio-demographically, and those socio-demographics have a real impact on the lived experience of certain seniors. But anyways, I think you made some really good points about involving seniors, and you're right. Seniors need to be engaged in finding solutions. They understand them better than anyone. And it's interesting because we often engage populations in looking for solutions, but I don't think we actually engage seniors in doing that as frequently as we do other sort of demographic variables and that. So I think that's a really good issue. And, you know, they bring a lifetime of experience and knowledge, and I would even suggest wisdom. But I think ageism sometimes gets in, you know, the way of that. And we just think of them, or maybe people think of me as that way, as just an old fuddy-duddy that really, you know, is not have good insight into sort of where the world is currently. And I think that's a mistake, but yeah. Rim or Grace, would you like to chime in on anything?
Yeah, I can. Oh, go ahead, Rim.
Go ahead, Grace.
Okay. I can speak to some of the research that Gateway has been conducting and some of the work they've been doing in our local communities on our local food systems. As Al and Kyle both demonstrated, there are definitely many challenges that our rural communities face. But I think we have to find unique ways to overcome some of these barriers. We're in a unique situation in rural communities in that we live amongst some of the most productive agricultural land, but we're still experiencing these vast challenges to accessing healthy food opportunities. And I think local food presents a promising approach to these issues and challenges. It's definitely becoming a growing enterprise across the province and could potentially meet the food needs of our rural residents and seniors specifically. So in building a stronger local food network, it does allow communities to become less reliant on global trade systems, which we witnessed multiple global trade breakdowns throughout the pandemic, with initially the flour shortages, but I mean, they continue to persist. So local food presents an opportunity to overcome that and avoid those global trade breakdowns. And specifically in terms of our rural seniors, local food sources provides them with alternative methods for acquiring food. So like Al had suggested, going to the grocery store, the anxieties around that, especially post-pandemic, local food offers an opportunity to avoid that barrier. And also is often a diverse range of food and increased nutritional value. So local food can present that opportunity in supporting the management of chronic disease, which is prevalent in our rural senior populations as well. So just from some of the recommendations from the Great Local Food Project, which took place at Gateway, exploring the local food landscape in Huron County. The first step we identified in utilizing our local food systems is to bridge the gaps between the mindsets of the producers and consumers. So providing information and increasing the knowledge and awareness throughout our rural communities on the availability and vast potential of utilizing local food and the positive impacts that they may have, will help to increase our uptake and benefit both the producer and consumer of the local food. Rural regions as well, specifically in our areas, many grocery stores have been shut down, which obviously presents the issue of transportation. So as Al suggested as well, oftentimes the response to this has been to establish food banks and mobile food trucks. However, these were never intended to be a permanent solution. They provide temporary relief, but don't address the deep-rooted issues and the root causes of food insecurity, such as housing, employment, income. So it's important to recognize that as well. And one of the goals of the Great Local Food Project was to map the local food producers in Huron County. And in doing so, we quickly realized the vast number and geographical spread of our local food producers, which could present a promising approach to reducing the transportation barrier and getting the local food products to our rural isolated seniors. And this would definitely be a more long-term and sustainable solution than food banks or mobile food trucks. And Kyle suggested as well, or actually I think someone in the question box suggested, the idea of social connection and the importance of that with our rural seniors. So I think it's important to reestablish the social ties with our seniors. And again, this has been extremely impacted by the pandemic, but we can't deny that social isolation and food insecurity are very interrelated. And I think that by collaborating with local food producers, it can create opportunities for community gathering and community kitchens, which would alleviate both the issues of food insecurity and social isolation, and also allow for the opportunity to improve food literacy. And developing connections and partnerships with our service providers and local food producers to develop community-based programs. So there's been discussion around mobile grocery stores or transportation services specifically for our local food producers to allow nutritious local food to be delivered to rural seniors is another opportunity, and came directly from our recommendations identified from the producers. And Kyle mentioned this as well, but ultimately, and it fulfills Gateway's mission as well, it's crucial to be culturally competent when developing solutions around this. So programming for seniors will be ineffective if they don't recognize it as a solution for themselves, or they're unable to access the services. So it's crucial to consider the perspectives of our rural seniors and acknowledge the unique context of rural communities to incorporate these aspects into implementing solutions as well.
Thanks, Grace. Just one comment on that. It might be a little bit controversial given the audience out there. I think we have to question what the food system production's for. And right now it's for the economy. It's not actually for producing food for people who live in the region. So the whole issue around food sovereignty, as we move into, a greater impact of global climate change and switches around that, I think food sovereignty may become a more important issue. And we looked at sort of those issues of production and who we're producing for and why. But, Huron County has great land, but most of the food production is for the global economy. It's not for people who are living in the region or that. So it may be something that we want to rethink. I want to bring Rim in. Rim, please jump in.
Thanks, Al. So I do relate to all of these challenges that were mentioned: physical access, food availability, limited food options, lack of transportation, and affordability. I want to add one more thing to these challenges as a dietitian working in public health and seeing how healthcare system operates. I think screening for malnutrition is lacking. And Al, you did mention that primary care providers, they don't include diet as part of their assessment. I think that's an important part, because if we're preventing malnutrition, then we're putting less stress on the hospitals and less expenditures. And prevention should start early as well. As Benjamin Franklin says, an ounce of prevention is worth a pound of cure. So we definitely need to ensure and stress a lot on prevention. And in order to allow for referral to other care professionals. So Al, you did mention referral to dentists for dentition, for example, a problem. Speech language pathologist could help with chewing and swallowing problems. A lot of seniors face challenges with that, especially if they have cognitive impairments, as well as referrals to registered dietitian for comprehensive nutrition assessment and follow-ups. We do have challenges with that for sure, and you did mention challenges with shortages in rural areas, shortages of healthcare professionals. Other challenges would be other solutions would be to promote social connectedness. And Kyle did mention engaging with older adults. And I would add to that, for example, referring them to congregate dining settings or community programs where they can interact with other seniors. We do have in the North several programs that connect seniors together, and they don't need to leave their home. For example, the Senior Center Without Wall. It's a program to build health literacy where seniors come together over the phone and they talk about multiple health-related topics. Other programs like Stay on Your Feet that prevent fall and offer exercise activities, and so it promotes social connectedness as well. There was also another program called Food Skills for Family. It's a food literacy program that brings seniors and adults together to cook together, and they come over for a meal and they eat together. So these are just some of the ideas. And we definitely need to work in parallel on the upstream level and advocate for to address the social determinants of health across the life cycle, such as income, housing, transportation, education, employment, in order to prevent older adults reaching at a later age and facing these challenges. So we need better public policy to address the root causes of household food insecurity, which is income, for example.
I think you raise a really interesting issue, Rim, in terms of upstream solutions. And one of the things that we need to do, we do need to emphasize upstream solutions rather than downstream. You know, in the literature, some people refer to the hospital or the healthcare system as a repair it system. You don't fix it until it's broke. But what we need to go with those upstream solutions is we need some really creative economists who can demonstrate how that is an investment that averts costs further down the system and how much it actually averts. Because I think if you think about, you know, people over 90 using $30,000 a year in healthcare resources, if you could take 15,000 of that and invest it in preventative care earlier, there may be some real savings. And it's not just about money, it's also about stress on the system. It's about burnt out healthcare workers and burnt out physicians. And so we need to understand, you talked a bit in your introduction about sort of bringing a systemic understanding to your work. And I know in Kyle's work, it's also the issue around systemic. And I like to think in my work, I look at things systemically, but we need to understand how things work together and interface with each other rather than work in isolation. And we have a preponderance to sort of look at things in isolation. So we look at the healthcare system, but we're not looking at the social determinants of health. So you're right, the social determinants of health, you know, we've seen the unraveling of the social safety net. Well, how much has that cost in terms of increased healthcare costs? We have labor practices, precarious employment. We know people who are employed precariously actually utilize more healthcare resources than those who have a decent. People who are food insecure utilize more healthcare resources than other people. So a lot of the problems that we create upstream in terms of, you know, income or just simply conditions for living, or we know that people, you know, with housing issues. So all the things that promote a use of the healthcare resources could actually begin to be thought about being addressed upstream, and then saving the amount of money, not to mention simply improving the quality of people's lives. And ultimately, that's what it sort of comes to, is improving the quality of people's lives. I think we have to be economically realistic in looking at those things, but I don't see a lot of creativity out there. I have a question for you though, Rim. Do you think that as a result of the pandemic, people have become more aware of the function and role of public health, and whether there's a greater openness to investment in that? I'm just curious. I have no answer to that question, but I'm just wondering what your perception is, or either Grace or Kyle too.
Yeah, thanks, Al, for the question. I definitely think that the pandemic has brought more awareness about public health, and people are more aware about the role of public health that we play in prevention and advocating for upstream solutions. But I think there is still more work to be done, and we need more investment in prevention rather than treatment. There's definitely more work to be done, and focusing on public policy and supportive health environments, building those supportive health environments and health promotion programs for sure.
Okay. Dan's back, so that means I have to turn it over to him, but I just want to take
you can
What's
keep
that?
going for 2 more minutes.
for 2 more minutes. Well, at this point, I'll just give Kyle, you want to jump in? No? Oh, okay. I just saw you raising your hand. Grace, anything you would like to add?
No, I don't think so. There are a few questions in the chat box. I'm not sure if you wanted to touch on 1 or 2 of those, or just provide a bit of a follow-up email to those questions. But speaking to Donna's question around opportunities for public procurement of local food, I think that's definitely a great opportunity and something that would be worthwhile exploring. There is a service in Huron County right now called Eat Local Huron, which is a not-for-profit organization of online farmers market, basically, that brings all the local food producers' products together and delivers it to people's doorsteps. So that's definitely one step in the right direction towards that public procurement piece of the local food.
Okay. I think my 2 minutes is up. I just want to take a moment to thank Kyle, Grace, and Rim for agreeing to participate today and offering their wisdom and insights. So thank you very much. It was a big ask on my part, and I appreciate your willingness to volunteer and be here with us today. So Dan, I'll turn it over to you.
Thank you, Al, and thank you, panelists. The frustrating part about these noon hour conversations is that there's always much more that we could talk about than there is time. But we will continue, I guess, with the current format and leave it with you, the panelists, and you, the audience, wanting more, as certainly I do. Al, thank you for reinforcing the issue of rural health and the fact that people who live in rural aren't as healthy. And your term of the life cycle of the baby boomer, being a baby boomer and being on the cutting edge of being a baby boomer, I'm very aware of that, and how that affects my life going forward. And I'm sure for many people, it's the same type of thought and conversation that goes on. And then also thank you, Al, for introducing us to nutritional risk and nutritional security and insecurity, as opposed to food insecurity. Overall, I would say this has been a fascinating and somewhat alarming conversation. There's no doubt the challenges for local government, province, and our country to care for marginalized populations, including seniors, to provide adequate nutrition, healthcare, and housing are significant. But bringing bright minds like yours, panelists, to focus on these problems and the issues is a good start, I think. And for everyone out there, today's lecture really demonstrates what Gateway is all about, bringing relevant health information and research data to our rural residents. Thanks, Al, for creating a conversation surrounding this topic, and thank you, panelists, for all your insight. I would just like to add that Al's research methodology teaching has paid big dividends for many of his students and for our area, hopefully in the future. We have some of Al's students who have been accepted into medical school and other professional areas of study and research. And hopefully someday they will bring all of that back to Huron County and help us out with all our health issues. I want to say a huge thank you to our sponsors for their continued support. Without them, this lecture series would not be possible, and they include CIBC Private Wealth Management, DeJager Town Square IDA Pharmacy in Goderich, Zehrs and Goderich, the Town of Goderich, Libro Credit Union, and MacEwan and Feagan Insurance Brokers, and HuronTel Cable TV for broadcasting us. Gateway Center of Excellence in Rural Health is a not-for-profit organization with charitable status. We greatly appreciate and welcome the support we receive. If you would like to donate to Gateway in support of this lecture series and other activities that we undertake, I encourage you to visit the Gateway website and click on the donate button. As well, Gateway sells a line of high-quality Gateway branded merchandise and clothing as one of its fundraising endeavors. You can visit our online store through our website. And with the holiday season upon us, we can provide you with unique Gateway merchandise that'll fill your gift-giving requirements. Thank you again to all of you for joining us today. We look forward to seeing you at the next lecture series event, 12 noon, January 10th, 2023, when Becky Higgs, Gateway Research Assistant, will be our speaker. She and her panel will be discussing a new Gateway initiative called Shed Talks, which is essentially a tool to promote good mental health in our farming community. To learn more about Gateway, check out our new website. It's definitely worth a visit. And we hope you will pass the lecture series information along to your networks. We hope to expand the reach of this lecture series with the aim of promoting the knowledge economy, reducing social isolation, and supporting Gateway's mission of improving the health and quality of life of rural residents. We at Gateway wish all of you a very happy holiday season and extend our best wishes for good health and prosperity in the new year. See you next year. Thank you and goodbye.